that at some point we need to transition from emergency response to more of disease management. And so we had been talking about that and planning for that, and then Omicron hit, so we delayed it a little bit, but I think that's where we're at right now, and this needs to be seen as another infectious disease and transfer back to the healthcare community and have the healthcare community deal with how they normally diagnose and treat various illnesses.
Aloha, I'm Robert Perkinson, coordinator of the UH Better Tomorrow Speaker Series, and I'm pleased to be hosting this conversation today on making the transition from emergency to endemic COVID. For a very long time now, we've been living through the greatest health crisis in a century. In the US alone, we've now lost roughly 1 million people, about the population of Honolulu. That's more than the war dead combined in World War I, World War II, Korea, and Vietnam combined. The World Health Organization estimates the toll internationally at 15 million. COVID-19 has upended transportation, healthcare, education, entertainment, employment, supply chains, mental health. It's interrupted everything. We're really living through history, but that also means we have a chance to shape it. At the very beginning of this pandemic, there was the hope that we might be able to fully contain and turn back the virus, perhaps driving it out of circulation in the human population. But it's so widespread now, the variants are so contagious that is beyond reach now. We're going to be living with this virus most likely for a very long time, so we have to coexist with COVID. How should we do it? And that's our topic today. How to move beyond the emergency while COVID remains a very serious threat. I'd like us to talk about what we've done right and what maybe we haven't done as well so far, how we can best manage the virus for the long term, how we can perhaps at long last address the systemic inequalities that made COVID so much worse, and perhaps how can we, out of this crisis, build out the infrastructure that we need to make ourselves safer, healthier, more resilient, perhaps even happier down the road. So I'd like us to think about how we might forge a better future out of this crisis. We have with us 4 amazing, distinguished guests who have been working literally around the clock, could say heroically, in fact, to address this crisis all the way through. Libby Char is the director of our Department of Health. She's a UH alumna, an emergency room doctor. Her department deals not only with COVID, but with Red Hill, which means she may have the hardest job in town. To my left is Mark Muguuishi, who is an entrepreneur, a surgeon, a winning basketball coach, and not least the president and CEO of HMSA, the state's largest insurer. He's also a key leader of COVID POW, the state's principal public-private COVID response collective. Also a UH alumna, Lee Buenconsejo Lam, who's a family medicine doctor, an expert in cervical cancer and health inequalities, and associate dean of the John A. Burns School of Medicine. She's also served as UH's main point person on the virus. And finally, Jonathan Dworkin, an infectious disease specialist, Queen's physician on the Big Island, and author of an excellent new book on Hawaii's COVID response titled The Plague Doctors. Let's start by assessing how Hawaii has done in the pandemic. By the numbers, we've fared much better than other U.S. states, and that really translates into thousands of lives not lost compared to the fatality rates on the continent. Libby, what do you think accounts for that? What have we done most right?
So I think the biggest thing that's kept our case rate and our death rate, about second lowest in the nation. I think that's really due to our sense of community and people pitching in and helping each other out, neighbors helping neighbors. We tried to take advantage of the Pacific Ocean. We've got a great border there, and we implemented some travel programs early on. And then just our climate, where we tried to keep people outdoors and open windows and do activities outdoors year-round.
Mark, we've also seen an unusual level of cooperation, private-public partnerships, and coordination. To what extent do you think that has helped, or other factors that you see that you think have helped us weather this better than other jurisdictions?
I think Libby hit it on the head with her use of the word community. We have this innate sense of ohana that's so valuable to us in Hawaii, where we care about our friends, our neighbors, our family, obviously. And so the concept of doing a public-private partnership, which was so powerful in this particular case, where government and businesses and people all got together to unify their response, it was natural. It just kind of happened.
Lee, what's your sense of how important masking has been since the practice of masking has been, there's been more cooperation, compliance, and longer extension of mask mandates than other places? What role do you think that has played for us?
Yeah, I think we're really lucky that so many people have really, I would say, embraced masking. Certainly not everyone, but there's been so much information about how effective the mask is in helping to reduce the transmission. And numerous studies from across the mainland and the world, certainly here. And it's been, probably one of the most important things to get everyone back in school and to keep them in school. And so you have to really balance the outages. So, we talk a lot about economics and the work, but the impact that this pandemic has had on the social emotional development and the mental health of especially the younger children, but really increased rates of suicidality in the teens and just numerous mental health and well-being challenges. So the masks have really helped us get back to our lives and staying in school. And so we're really happy here at UH that we kept the mask mandate in for all instructional classes, as well as close, venues, labs, and whatnot, because here we are at the beginning of May, and with a very transmissible, contagious virus, and the masks are helping people to stay in school and take their finals. So,
Jonathan, travel restrictions globally have not worked very well against COVID, any of the various variants, but what's your sense of how well they have played a role in protecting people in Hawaii as an island environment, which is kind of distinct from other geographies?
Yeah, I think we have to distinguish between border restrictions and travel controls on the continent and in Europe and how it plays out in an island. If you look at successful pandemic responses around the world in other islands, whether it be Hong Kong, Taiwan, or New Zealand, they all involved, particularly early on, leaning into their geography and using some kind of travel restriction, either a post-arrival quarantine or a post-arrival quarantine that you could test out of as a means of retarding the progress of the virus. And this was particularly important in 2020 and 2021. I think it's becoming less important as the virus becomes more contagious. And at this point, places that are relying solely on these types of non-pharmaceutical interventions are not doing as well. We saw a big mortality event in Hong Kong recently, and they have an excellent public health system, but they didn't do a very good job of vaccinating elderly residents. And having a good public health system was not enough to protect those people. So you need a layered defense. And for Hawaii, I think leaning into the geography and using the Pacific Ocean as essentially a giant moat was an incredibly smart thing to do in 2020 and early 2021.
With the benefit of hindsight, with the knowledge that, there's been a lot of research on this virus, so our knowledge has changed tremendously over time. Treatment protocols have evolved, availability of vaccines and pharmaceuticals, all of that has changed. But, based on what was knowable at the time, with the benefit of hindsight, do you think there's some decisions that we could have done better, places we stumbled?
I mean, I don't know that it's a decision. I think part of it is early on that infrastructure to really engage the communities was really not built out in the way that it should have been. And so I definitely hope that's, one thing that will continue going forward. Because we did see that many of our most vulnerable communities, whether it was because of they were at high risk because of their jobs or because of housing or because of access to the internet or English or a whole host, that wasn't really in place like it should have been. And so I think that really did contribute to some of the very high disparities that we saw in both cases and mortalities.
I presume you were not in charge of the Department of Health at the beginning of the pandemic. We should be clear, but I presume that the the staffing and the funding and the infrastructure wasn't what we would have needed it to be. Are there other, so that's maybe something we let atrophy. Are there other mistakes or missteps that you think that we?
Well, I think, it's challenging, right? Because at the time we didn't know what we didn't know.
Exactly.
I think tagging on to what Lee was saying, the communication was a huge piece that wasn't there. And I think a lot of it was that we just didn't know. But even getting messages out to populations in their language, in their culture that they could understand, I think we could have done a better job with that. I think we have since really stepped it up, but I think early on that was something that could have been a lot better.
What's your sense, Jonathan? I know very early in the pandemic you were advocating for, quick action. Do you think we could have acted even faster? We acted faster and more in a more robust fashion than most places in the U.S., but do you think that we could have taken more aggressive steps, or that there's?
There were some, we could point at specific things that didn't go well at the beginning of the pandemic, both nationally and locally, testing being one of them, contact tracing, availability of isolation and quarantine hotel rooms. But if you look at it thematically, there's a theme that sort of unifies all these problems we had early on, and it was a sort of inflexibility of approach, where we had a lot of, we had a lot of concern over turf. Is this a state responsibility, or is this a county responsibility? Is this a private responsibility or a public responsibility? How are personnel assigned, and can we be creative in reassigning them if we need to? How are we allowed to use tests, and can we redefine how we use tests if we want to do that? When you look at what we got wrong, it almost always involved those themes. And if you look at the places that really had the gold standard responses in 2020, 2021, places like South Korea, for example, rather than being focused on the noun of pandemic response, on the who and the what and the where, they were really focused on the action of pandemic response, on the verb of pandemic response. So they had a goal, to get everybody tested after they arrived in the country, to separate infected people from uninfected people, to make tests widely available, to have locally developed tests that were not susceptible to supply chain disruptions. And they were very creative in accomplishing those goals. And they didn't get caught up in who was doing it, or who was allowed to do it, or who was not allowed to do it. So if I had a critique of our response, both in the United States in general, but Hawaii specifically, it would be to sort of abandon this idea of, well, you're responsible for this and you're responsible for that, and instead focus on what we're trying to accomplish with a pandemic response and be flexible in how we get to that.
I imagine we'll be telling stories about this pandemic for decades to come and our experiences in it, but what's something that you've learned?
The main lesson I learned is that you have to be ready. You can't expect to battle a pandemic if you have inadequate infrastructure. And we weren't ready. And so we were trying to build the airplane while we were flying it. That doesn't work well typically.
I think the importance of, so we spoke about communication with communities, but also communication across state agencies and between state and county and with the hospitals and the health systems, because once that was better established, we were able to move a lot faster. And so even say with our vulnerable populations who live in community care homes or foster homes, there actually really wasn't a great way to push information out, and importantly, to get information back from them in terms of what types of needs they needed. And it took quite a while actually to build that, but we need to have that. Okay, so that's part of the readiness and the infrastructure, is that internal and external communication, and very, very rapid communication.
What's your sense, Libby?
I don't have a public health background, and I have, since taking this position, really learned the value of public health. And I think it's fair to say public health saves lives.
I think also I should say that being an emergency room doctor is probably pretty good training for dealing with an emergency. You're used to improvising and triaging and making decisions quickly based on imperfect information, maybe more than some other fields. Do you think that helped?
Oh, I definitely think that helped. I think, it gets back to what John was saying again, though, is that you're trying to do things and there are a lot of barriers that pop up, like, well, you can't do that. This is the way we've always done it. And that's, that's for somebody else to do. That's not, whose lane is it? And rather than just saying, we're all moving in the same direction, let's just go.
One thing I've been amazed at It's the same lesson I've learned from climate change, is that the science is difficult, in this case amazing, the speed and efficacy of vaccine development, the research coordination, the public policy formulation is difficult, but none of that is as difficult as moving the political process and communicating with the public and building good ideas and sound information in public culture, which makes me think my field in the humanities and the social sciences are important too, as well as all of those others.
Absolutely. Yeah, and it's about building the trust, right? And in the case of the United States, regaining trust in science is really critically important. And so how we communicate, I think how we engage very diverse stakeholders who have very different viewpoints, it's actually really, really critical to rebuilding that trust.
I think leadership sometimes comes from unexpected places, and having a degree in a certain field does not by itself make you the best person to be in charge of something. And I was relieved when Dr. Char had an opportunity to go over to the health department, because I think we needed an outside perspective there, and we needed an emergency management perspective. So, the value of honesty would be the other thing. And being able to admit when we don't know things, being able to admit when we made mistakes, being able to explain what we don't know and why we don't know it and what we're doing to try to learn. We talk about institutional trust all the time, but the way to build institutional trust is to be honest and to be transparent. And that's an area where we've occasionally fallen short. So I would hope a future generation confronting the same problem would see our struggle with that and would immediately move in that direction.
Still looking back on where we've been so far, what's quickly one thing you're proud of in your organization and a decision you made, people you work with, an encounter you had with a patient even? Mark, does anything jump to mind?
Yeah, I think for us, we quickly in the beginning tried to mobilize a lot of our team, our analysts, our executives, and tried to cooperate in helping the state form a framework by which they could approach this, putting a lot of the responsibilities, day-to-day responsibilities on the side in order to get this done. And I was really proud of the fact that our organization came together to do that.
If I had to pick one thing that we did, I think we did well with the vaccination. I think we put that together kind of on the fly. We did it really well. And again, it gets back to collaboration. That happened because the Department of Health partnered with hospitals and private entities and the university and volunteers and the National Guard and the counties and everybody, the health clinics, and I think that's why it worked well. I'm pretty happy with the way that turned out. I think we've done a good job with that, and we have consistently been in the top 10 states for getting people vaccinated.
Yeah, and I noticed with students, friends of my daughter and so on, that having very low impediments to action can make a very big difference. And for a while, when everything was robustly set up and funded, you could just walk in and get a vaccine practically anywhere. The bus was almost following you around. And and it's now a little harder. I got my second booster today and I had to make an appointment. It was kind of irritating. But it's better than them throwing away.
Still widely available.
It was still easy to do. It was fine.
Yeah.
It just took a little effort.
Yeah.
One thing you're proud of?
Well, I think the pandemic has made me realize that I'm in the right profession. And that was not always intuitive to me. As a young person, I had doubts about going into the sciences and going into medicine. I had other things I was interested in. But working alongside nurses on Tower 9 Diamond Head at Queens Punch Bowl at the beginning, working alongside doctors on the COVID units, seeing the basic heroism up front at the very beginning that they showed, their ability and their resiliency to stick through it and to defend the state. I've never been prouder of my colleagues, and it's something that I'll carry with me for the rest of my life.
So early on in the pandemic, we had folks from not only medicine, but nursing, public health, social work, economics, from the laboratory sciences, from tropical medicine, just really almost every part of UH was very involved. With the community health worker training as well. And so this is UH West Oahu in partnership with many others. And then on the clinical side of UH, so again, really through, all of the different programs, the residency programs that, we have, that flexibility. So pulling together and this incredible ability to pivot in 3 weeks to, telehealth and figuring out how to do education differently so that we could continue the education of our health professionals. And that's really pretty amazing. And I think also showed UH internally what we really could do, together across the entire system.
Right, that's true. We were able to delay widespread transmission in Hawaii until, I think, Delta,
Yeah.
roughly. But, the virus is really contagious now, so we're not able to do that. It's a lot of people have had it. A lot of people are still going to get it. It's not going anywhere. We can't politically, it's not possible. Legally, it's not possible. And it's culturally, it's not. Socially, it's not really possible to continue all of the restrictions that we might favor if we were only focused on the epidemiology of the disease. But still, it's not easy to make this transition. How do we move from emergency footing, Libby, to coexisting with this virus while it's still not gone?
It's been 2 years, and we always knew that at some point we need to transition from emergency response to more of disease management. And so we had been talking about that and planning for that, and then Omicron hit, so we delayed it a little bit. But I think that's where we're at right now, and this needs to be seen as another infectious disease and transfer back to the healthcare community and have the healthcare community deal with how they normally diagnose and treat various illnesses. That being said, I think the Department of Health still has a responsibility and a role, and government in general, to provide the surveillance and to make sure that we're backing up the healthcare system, and to the extent possible help with funding where we can, and I think going forward, trying to capture the lessons that we learned along the way and not be caught flat-footed if and when the next thing comes along. So trying to really build that infrastructure. We need to step up our data modernization. We need to make sure that there's equity in healthcare, and that's kind of what we're heading for now, what we're really trying to beef up, if you will, as we transition.
One factor in determining what sorts of protocols we have in place is, of course, the imperfect measures of the dangerousness of the virus. Jonathan, what's your sense, working with COVID patients so regularly? There's not so many people who are fully naive to the virus at this point. Many people have had it and or are immunized. What is the data showing in terms of the dangerousness of the disease to people who are not entirely naive?
Yeah, we're dealing with a less dangerous virus than we were 2 years ago. And there's to piggyback on what you were just asking, Libby, there's a line of thinking that because we're no longer controlling transmission, that somehow the attempt to control transmission in 2020 and 2021 was a failure. And I don't agree with that. I think delay was a perfectly valid tactic to use in 2020 and 2021. And every month that we delayed a massive outbreak was a month that we saved the lives of hundreds of residents in our community.
Well, and it gave time for vaccinations to come online, therapeutics, treatment protocols to improve.
So this was entirely appropriate to do what we did in 2020 and well into 2021. Now, the situation changed, and the virus has a vote. And when you're dealing with a much more transmissible virus, you have to adjust what you're doing. And we now have vaccination, which reduces your chance of being hospitalized and having pneumonia by about 80 to 90% if you're up to date with your vaccination. And what I tell my patients now is it's really a layered defense. And the first layer is vaccination, is being up to date with your vaccination. And if you're up to date with your vaccination, just doing that alone dramatically reduces the chance that you're going to end up in the hospital with pneumonia. But we also have other things we can do now. We have pre-exposure prophylaxis with monoclonal antibodies for high-risk patients. And there's a medication that we can use that lasts about 6 months that reduces hospitalization by about another 80% in the higher risk population. And
these are for immunocompromised?
These are for immunocompromised people. And I'm lucky. I'm in a small town, Waimea, where we have one oncologist. So I walked into his office and we sat down. I said, I want to give this medicine to everybody that you see who's at risk of having a bad outcome with COVID. And let's just do it. So we've been doing that for the last couple of months. And then we also have early antiviral treatment for people when they become infected. And it works if you give it early. If you give it within the first 5 to 7 days of an infection, you can further reduce the risk that somebody is hospitalized. So, at the beginning of the pandemic, we had not that many cases, and it was translating into a lot of hospitalizations. People were coming in with bilateral pneumonia on their chest x-rays. They were hypoxic. They were in respiratory failure. They were dying of organ failure. The vast majority of my interactions with COVID patients now are mild outpatient respiratory illnesses, and we treat them immediately if they're high risk. And I tell them, I want to treat you within hours, not days, hours. And if we do this and we get this therapy out and we make it accessible to people, there's no reason why we need to have a huge wave that inundates the hospital. But the challenge is making these therapies easily available for people.
At the statewide level, Libby, what's your sense on what we do to best protect people now who are most vulnerable, either immunocompromised, comorbidities that are dangerous, maybe still unvaccinated? What can we still be doing to try to...
So we still have a lot of work to do with regards to that health equity piece and getting vaccines and making it accessible to people who are in high areas that have a lot of health inequity, to make it just available for them. You know how you were saying that it was easy before, you were falling over places that were vaccinating and now they're hard to find. So to make sure that for those populations it's still very easy to find. Go to their homes, go to where they live, make it easy for them so they don't have to, that was one of the comments we had from a woman who was so glad when we showed up in the building that she lived in, because she had wanted to be vaccinated, but she's a single mom, and by the time she got the kid to school every day and and went to work and picked the kid up and got the kid home and fed and got to her second job and got home at night, she didn't have an opportunity to get vaccinated. So those kind of situations, make it accessible. We still need to vaccinate. We have about 320,000 people that are not yet vaccinated with their 2 doses.
If you look at some models across the world, Norway, for example, has these public health nurses. So they're assigned a geographic area, maybe 1,000 people. They actually go to their homes and they take care of them for a vaccine or for even a therapeutic. If somebody got COVID, they would bring the drug and say, here you go. So maybe we don't have a workforce of nurses that can do that, but community health workers can do that and actually may even be more accepted in communities where they are culturally relevant to the people that they're treating. So that's another piece of infrastructure we can look at in the future to be ready. Can we beef up the robustness of our community health worker program so that they're out there addressing health inequities and bringing therapeutics and vaccinations to people who need them?
Well, and that can help with...
Yeah.
That can help with diabetes.
Chronic
and
disease, cancer screening, everything.
Yeah.
I think the other piece, besides getting the vaccine and the therapeutics and having folks actually know how to access it, is actually PPE. So for some of our most vulnerable populations, those who are homebound, and so again, living in community care homes, foster homes, those who can't drive anymore and have kids that are working 3 jobs, it's actually really important to have a distribution system to get masks and gloves and other things like that. And we actually had a really hard time doing that initially. And so for whatever infectious disease outbreak, again, having that communication, but also that distribution system could be through community health workers. It could be, could be elsewhere. And but we don't have enough people, like some of our medical director of Medicaid, who would actually drive PPE to people's homes. Like, thank you, Dr. Toma. But, that's not sustainable. Yeah.
As we transition to managing COVID long-term as other infectious diseases, because there's lots of them circulating and lots of them are really deadly and difficult to deal with. Part of the question about how we do that depends on how we balance different imperatives. And I know at UH, what's your thought of how we balance protecting people and how we've done, protecting people, reducing transmission, but also facilitating student learning and bolstering student well-being and mental health for the whole community, because that's no small... Isolation has lots of profound consequences.
Right. So the key is really to focus on making sure that our learners are learning in the best possible environment for what they're learning. And so what I mean by that is, we have learned that there are some courses that actually could be taught online pretty well if you truly design it to be taught online. And in fact, there are some populations of learners, like those who are working and taking classes afterwards, where it really does need to be online. And so that's fine, that has to continue. But there are many, many courses that really you do need to be in person. And so the key is to always just think, for us, is are we doing the best for our students? So looking at student success, student outcomes, and a lot of student success is really that socialization piece. And so balancing, the masks and, limitations on college events and other things, it's important to really look at the whole student and the whole student experience. We have a lot of, maybe faculty or staff who are at higher risk because of their age or whatever, but that's why masks are strongly encouraged. And if people want to wear their mask, it's completely fine.
How do you think we've done, Mark, overall at balancing those public health and economic interests and social supports?
Well, I think in the beginning, when this was truly a pandemic and lives were at stake, I think we absolutely made the correct choice. You can't have a robust economy with a lot of dead people. Like, let's just be transparent about that. But on the other hand, once you start to get control of it and you're coming out of it, public health is important, but poverty is the worst enemy of public health. So if you can't bring back the economic activity so that people can have healthy lives, enough food on the table, purpose in what they're doing, all those kinds of other things that come with a robust economy, you sacrifice your long-term public health. And there are lots of examples of cities who lost their economic vitality and then dropped their life expectancies 10 years. And we don't want that to happen to our next generation. So I do think we need to pay attention to that. And it's going to be some of these infrastructure investments that we make today that prevent us from having to shut down like we had to do before, to get us back on track, to make sure that we pay attention to those things.
Mm-hmm. One challenge now, of course, is tracking the virus. It's a little more difficult that people are doing most of their testing at home, so they're not really necessarily reporting them to authorities. It seems like cases are going up quite a bit, but our surveillance mechanisms are imperfect. What metrics, Libby, do you think we need to watch, and what surveillance technologies maybe do we need to have in place, more robust wastewater treatment monitoring, for example, in order to keep track of how we're doing with the virus, just in case we do need to slow transmission at some point?
So I think, the days of watching a number are gone. We have so much more and we're more sophisticated now. So I think it's taking all these things in context and watching globally what's going on. As long as there are pockets around the world that are still, not adequately vaccinated, we're going to see the evolution of new variants. I think for us, not being able to pick up on all those home test kits is a real problem. It's a blind side. So, I've been reading about other systems where you can do a home test and then, log in voluntarily, but you can log into a website or something and just say, hey, I had a positive test. Can we do something like that? So we're looking at data modernization in what we do in electronic lab reporting systems, something like that. For sure, the wastewater management, where we can test, I think that's really important because we've seen it work so well in other states. I mean, they knew their cases were about to go up before they actually started getting the positive test. They were picking up variants before they actually had isolated it in people. And so I think to be able to watch those trends is going to be more and more important going forward.
I know, Jonathan, you were mentioning the other day that you wish we had quicker analysis of the genetic sequencing of the virus, because those have treatment implications in terms of what monoclonal antibody treatments, for example, are effective. Thoughts on, Hawaii's a small place, but thoughts on the kind of infrastructure that we need, or the sort of reporting that you would hope to get?
Yeah, I think we have a good variant report that comes out that I read and I think is very well put together, and I just want it to be a little bit more timely. I'll just give you a couple of examples. During the Delta wave, we were using one monoclonal antibody. Then when we had the Omicron wave hit, we had to switch to another monoclonal antibody. And now we're in the BA2 subvariant of Omicron, and we had to switch to a third monoclonal antibody. So as the guy on the ground who has to treat the patients, we have to make decisions at the hospital level as to how we're going to stock our pharmacy. And we have to pick the time to switch from one monoclonal antibody to the next. And we're not likely to be able to get the genotype on each individual case. So we're not individualizing that. What we're looking at is for an indicator of what's going on in the community and when it's rising. So my feedback to Ed Desmond was, hey, this is a great variant report. Can you make a one-pager that comes out once a week for each island, just so that we know what's in our community? And that helps the hospital plan what drug to stock, because this stuff changes very, very quickly. So I think that's kind of the gold standard now, and you see that in other systems, wastewater surveillance, and also timely updates to variant reporting.
Is it feasible for UH or DOH to kind of do in-house sequencing, or is it?
So it would be nice to have a wider capacity. So it's done at the state lab, so it's done through government. And I believe Tripler can also do it, but none of the private labs are able to do whole genomic sequencing.
What would you say, Lee, to people who feel like we're relaxing all of this way too fast? This is still an emergency. Everybody should still have on masks all the time. They're kind of hunkered down and think we should all be there. What, either maybe you think they're right, or what words of assurance might you have?
Yeah, I think the key part of it is really that shift to more individual responsibility now at this point. And, all of us, again, really trying to message that there are certain cases where mask wearing probably does make a lot of sense. Again, very large crowds in particular. But, if you have your own risk factors, or you live with a family, or, whatever situation, wear your mask. But it's also equally important to get outside and to start doing some of those really important things for the rest of your health. Because again, there's a lot of data that show increased rates of depression and anxiety, obesity, and with obesity comes diabetes and heart attacks and everything else. And so there's, I think, just really working on the messaging and just the communication with individual patients, but also communities, because there's more to health than just this virus, right? And so really realizing that you have to be very holistic in your approach. And so, yeah, wear your mask, but please go out and start to do other things.
Why not have a more nuanced mask requirement policy where it's still required in movie theaters and concerts, but is it for legal reasons, or just that you felt that it would be too complicated to try to?
I think it's multifactorial, and some of it's policy and some of it's practicality, and I think you, as long as people have the information, then you can decide whether you're comfortable going to a movie theater with or without a mask. You could go to the theater and wear your mask. You could go to the theater and not wear your mask. But I think as long as you have that, you can tailor it to yourself. Like Lee was saying, it becomes a personal decision. I don't know who's at home. I don't know if you have, if your spouse has leukemia or something and is immune compromised. So I think allowing people that flexibility, as long as we provide the information, and then for the rest of us, and that's one of the things I think is really nice in Hawaii, is people are very tolerant of each other, whether they're wearing a mask or not. I'm wearing a mask here. I haven't been ridiculed yet by any of you. You're not wearing a mask, and I'm totally fine with that. So I think allowing people to make their
COVID from this interview.
Yeah.
allowing people to make their decisions.
Yeah, and I do want to add to Libby's concept that people should be empowered with enough information to make personal decisions. It was referenced, I think, also by Libby earlier about the need for really a standard data reporting system that's not one number. That is part of the reason why people are afraid, because they'll see this number and they'll go, oh my God, there's still 200 infections, I can't go out. But it's not really that. It's how many people are vaccinated, how available are therapeutics, what's the seroprevalence, so that you understand all of those things, and based on all of that and a common understanding, you can assess your own personal risk.
Can I jump onto that a little bit? Because I think one of the most common questions I get from patients now is around this set of issues. Is it okay for me to do this? Is it okay for me to do that? And in our community, the way I've been reassuring my patients in Waimea is I've been saying, well, listen, let's make sure you're up to date with your vaccination. What have you had? When have you had it? Do we need to get you a fourth shot? If we need to get you a fourth shot, let's do that. Are you a candidate for pre-exposure prophylaxis? If so, let's do that. Okay, here's our clinic number. The moment you get infected, we want to hear from you so that we can get you early antiviral therapy, right? So we're trying to deliver the goods, and if you can deliver the goods, patients are going to say, okay, I am safer. Someone's looking out for me. The healthcare system is functional, right? But I'm still getting messages from people all around the state who are having trouble accessing stuff. And it tends to be scenarios like, I think I need Evusheld, but I called my healthcare center and they don't know anything about it. And they're saying I'm not allowed to have it. Or, I tested positive this morning and I tried to get an antiviral therapy, but they told me I need a confirmatory PCR test. And then I asked to schedule a confirmatory PCR test and they said everything's full until next Thursday, right? So people are smart and they realize that the system's not functioning well enough to protect them, and then they're anxious. So I think the impetus is on us to make the system work. And then when we reassure people, they're going to feel reassured.
Make it work and bring it to the people through community health workers, I think, too.
Right.
Yeah.
And I've been having those same conversations with all of my highest risk patients. I make sure they understand what are the symptoms, what are the risks. I actually gave some N95s to a couple of my cancer patients just so that they could have it, when they're really out. And made sure that they knew how to call the clinic, because there aren't as many restrictions now with the oral medication as there was maybe 2-3 months ago. But they really do need to have it at their fingertips. And that also means having a live human pick up a phone, which, is sometimes hard.
Exactly. Yeah.
Let's shift the conversation a little bit to home in on health inequity, because it's not like this pandemic hit everyone the same, or that communities were equally vulnerable before the virus even ever arrived. By some measures, because federal and state government really pumped a lot of money into the economy, unlike in some previous economic crises, 2008, for example, the economy didn't collapse. Actually, because of the tax credits and stuff, child poverty has gone down a lot. We'll see what happens when some of those tax credits federally expire. A lot of low-income workers got a sabbatical for the only time in the history of low-wage capitalism. So there were some positive developments for people on the lower part of the income scale. But, it was also true that COVID was most devastating in the communities that were already having the hardest time. It, really hit the Filipino, Native Hawaiian, Pacific Islander communities here. You're kind of an expert in this field, but what have we learned, or what does everyone need to know about the social determinants of health and health access and inequality in Hawaii?
Yeah, so I think that, over time, the community did have more of a voice, an actual seat at the table. And, one of the big things that was a big turnaround, I think, was when Department of Health was able to hire some of these key members from the communities who could help staff the 211 line and get people to the right, sort of resources very quickly. So I think that that community engagement but true, meaning actually having a mechanism to hire and pay, not just ask someone on their volunteer on top of their third job, type of situation. And I think that model will actually really help everybody, because again, you're using the natural community strengths, but then you're also augmenting with actually some income, which again will just really help. So I think that's pretty important. That whole system of community engagement is really critical. And then again, making sure that we have these systems so that they can still stay at the table, I would say. So and also having this all health and all policy approach, which we really don't have in the United States, but that's really what's needed to address the social determinants of health.
Libby, what do you think we've done fairly well in kind of trying to help our most at-risk residents, people who don't have housing, people who are imprisoned, so they have too much housing from their perspective, Pacific Islanders and so on? What have we done well, but where are we still falling short?
I think we've had a good awareness that this is absolutely something that needs to be addressed. We have people who are very dedicated to doing public health, specifically as it relates to health inequities. We're working on creating an Office of Health Equity, under the Department of Health. And prior to COVID, the Department of Health was actually putting together a community health worker. And we were doing it online so that people who didn't live in Oahu could still do this training. And we were trying to bolster and boost the number of people from within various communities that could then serve as that liaison for their community. And it was a very entry level, but if you could get a job doing that, you know, that opened doors for you to then move up or sideways, or, you know, just job opportunities. And it would be people from the community. And so that's what we were really headed for. And then COVID came and everybody got busy and it was put on hold. And then through partnership with the university, and that's been one of our workforce development things, is that this is really needed. And so to be able to hire people from the community to be that voice and to work. And I think a lot of this is back to about 2009 or so, on the last recession. We had public health nurses embedded in communities, and that was their job. They were within the community every day. And those jobs were all lost. And I think COVID, part of the rocky start was that we didn't have people actually embedded in communities. And so when COVID hit, you didn't have those relationships. You didn't have that two-way communication. And I think that's a lesson going forward, that we need to rekindle that. We need to work with people from various communities. We need to have people in communities. And, you know, it gets back to making sure that you have those jobs. How are you going to fund it? We need to make that a priority, that is a valuable resource, and we just need to fund it.
There's a common theme that's emerging here, that an effective health system really needs to be very attentive to the whole patient's needs, that we need to have leadership from the diversity of Hawaii's communities, even those most disadvantaged, and that we need to have folks really in those communities. And that would help, right, not just with COVID, but a variety of
the
ailments.
Entire chronic disease response, infectious disease control, everything.
One question I had for you was about diabetes, because that's a very complicated illness and very pronounced in Hawaii, that maps to some of the same economic inequalities and correlates quite troublingly with bad COVID outcomes.
Yep.
You know, what's your sense of what we could be doing better if this presents an opportunity to bring more resources to the task in terms of diabetes control in Hawaii?
Yeah, controlling diabetes is a multifactorial issue, but in the context of health equities, it's definitely true that health outcomes are worse in underserved areas. So it's a common theme, and you don't want to sound repetitive, but the only way you get somebody to care and understand about what they need to do is you have to speak their language. And, you know, I use that.
Literally and figuratively.
Literally and figuratively, but that's where the value of somebody embedded in the community, being the communicator and the bringer of that care, is so powerful, because they'll do both. And that's why it's so important.
You know, we do pretty well in Hawaii in terms of ensuring a larger portion of our population than other parts of the U.S. Still not nearly as well as other countries that have, you know, full health care for all. But are there, you know, significant policy fixes that you would like to see that would help us get more regular care to that final part of the population that we're not quite?
I think, like Mark said, it's multifactorial, so it's not just funding. It really is creating that network that at every level, so from very, very basic healthcare work, community health workers, all the way up to having access to, you know, the healthcare providers, the physicians, the nurses, the specialists that you need, and having it really accessible for people, you know, so that you don't have, it's not a burden for you to try and seek care or seek that access. And so it's not just about the funding. I think it's really building it. And can people make a living wage in these various professions? Because if not, we will always have shortages in them. And I think one of them we were dealing with was a nurses' aid program. We were trying to be creative in how we could, you know, enhance that through the university and that workforce development. So I think there are a lot of pukas right now that we need to fill, having to do with workforce development. And until we solve some of those issues, I think we're going to have shortages and access is going to be limited.
Well, then, go ahead, John.
I was going to say primary care on neighboring islands is a major issue coming from the Big Island. You know, a lot of the patients that have had dismal COVID outcomes are people who can't access the system, who have no entry point into the system. Someone has to prescribe your early antiviral therapy, right? And there are a lot of patients on the Big Island who have zero access to primary care, and this has been a chronic problem for years. I've had so many patients come to me begging me to be their primary care doctor. I'm not a primary care doctor, but I've at times been tempted to try to take on that role because people need it so badly. So I'm not sure what the policy fix there is, but we need to find a way to encourage young physicians to go into primary care. And when we have primary care physicians, we need to make it less miserable for them to practice in the community, particularly in rural communities. I don't know what the exact policy mix there is. It may have to do with student loan. It may have to do with overhead. It may have to do with the practice environment, with the support from the subspecialists. But there's a lot there that needs to be fixed, I think, for us to get where we want to go.
Yeah, and as a primary care physician, I think part of it is also really building the network so that we can work more effectively in teams, and teams within the community, but teams also across the islands. I think that's something that, through telehealth networks and other kinds of things are really have a lot of potential, but I think we haven't quite gotten there yet. And, a lot of people are working on that. And there are some policy pieces in there in terms of, payment and, but even something getting back to diabetes, dietitian services, right? Or social determinants of health, transportation to your doctor. So some very basic kind of traditionally non-medical things.
And not so expensive, actually.
Yeah,
some of those things.
I mean, if you can think about it, that transportation is really key, and understanding what you eat, and having someone to work with you within your resources to help you, access, not all of us can afford very expensive organic produce, right? And so, but having that whole network of folks to support patients and families, but that also means then that they can, be paid and make a living out of that. So there's a lot of, it's really very complex, but those are really important things.
We've started already talking about, the sort of healthcare system and public health infrastructure we would like to have. I want to encourage us for a moment even to think bigger, because I'm a historian, and crises of global historic proportions sometimes generate generational changes. It was out of the Great Depression that came all of the social supports that greatly alleviated poverty, didn't eliminate it, but alleviated it. Social Security, notably among the interventions. Out of World War II came even more of those. The GI Bill that tremendously expanded higher education and set the stage for economic transformation. So, if we can imagine or bracket for a minute all of the political realities that all of you have to be constrained by all the time, what sort of, but recognizing that we're a wealthy society, maybe what sort of Department of Health would you like to be in command of if there were, if the resources were really robust?
Yeah, I think to build a very kind of a global public health system where people earn good wages even for, jobs that don't pay that well right now, so that they could have that one job and earn a living doing it, and they could subsist on that, not only for the public health side, but also for the environmental health side. That's going to be becoming more, increasingly important and increasingly visible. But if we could support people at that level, that would encourage people to seek those jobs and to go through that training and to take those jobs and to stay in those jobs so that we're not chronically short. And then I think from there, if we built a really good foundation, then from there we would start seeing people moving up, and maybe you really enjoy what you're doing and then you go on to nursing school or RT school, or you become a dietitian or something like that. And I think that would really help to build. But as long as those lower paying jobs in our society are that low paying, we will always have a shortage of them, because you can't survive doing that kind of work.
Well, and we saw this as public health consequences, right? Like how many people in care work had to work 4 jobs in 4 different nursing homes. And that suddenly made it pretty easy to transmit COVID among even locked down residential facilities. So,
Yes.
or not having sick leave. What's your sense, Mark, of social supports that we might need to be a more resilient society?
Yeah, I mean, I think, like Libby said, funding for the right things, all the health-related social needs. If you want to improve health, you have to fund those, obviously. Transportation, food, housing, all that kind of stuff. But that's like boiling the ocean. Those are such huge social problems. On the health side, I think one of the first things you can start, which is exactly to Libby's point about the healthcare workforce, is figuring out the ideal team that creates team-based care and embedding those teams in places where they can be effective. Because I think we all know, me as an old coach and everybody else who's ever worked on a team, you're always better off in a team-based situation than 5 individual people working in a silo. Then you have questions of like who's getting paid what and who's doing what and whose responsibility is what, and this person's regulations make them do this and not that, and then nothing really good comes out of it. So I think if we completely revamp the model of care, the way we deliver care, that would be my vision of something that we could do in the next 20 years maybe, as opposed to some dream that could never happen.
Sure. Lee, are there additional investments you'd like to see, or
Yeah,
institutional
I think
transformations?
in terms of social determinants of health, it's poverty and education. So we also really do need to invest much more heavily in education, K through 12 and everything, because our next general workforce, they're in middle school and high school right now. And we really do need to strengthen that so that we have enough workforce for the entire, for the entirety of society. And along though with education, broadband, internet access, digital equity, all of those things are really important. Because if we do have another situation where we do need to shift suddenly back to online, we really cannot leave huge pockets of kids. I mean,
Disconnected.
We're unfortunately, we already are pretty poor in terms of math scores and, science and English and reading scores compared to the rest of the 50 states. And, we're really worried because now these 2 years, could really translate to being 4, 5, or 6 years behind. And we really can't do that again.
Jonathan, your chance to dream big for a moment.
There was an article that I recently read, I think it was in Nature, and they looked at spillover events where a virus transmits from an animal reservoir to a human reservoir, and they tried to model the future of this, taking into account global warming, taking into account urbanization, taking into account climate change. And they ran a bunch of computer simulations, and their best guess was that there's going to be 4,000 such events by the year 2070, where we have some kind of spillover. Now, we think that the vast majority of those are not going to result in a pandemic, but maybe 1% of them will, or maybe 0.1% of them will. We don't really know. And I think one of the...
This may not be a 100-year flood.
This may not be a 100-year flood. This may be a 10-year flood. And I think we have to understand that as the world changes, we are going to be disrupted. Again, it's going to happen. And what is our level of resiliency? How self-sufficient are we? Do we have infrastructure in place coming out of this pandemic that allows us to navigate this when it happens again? And it seems to me that we were maybe a bit too quick to go back to the 2018, 2019 economic model. And I understand why. I get it. But when this happens again, wouldn't it be nice to have a small but respectable biotech sector that can develop tests for us so that we can improve our security? Wouldn't it be nice to have software that's locally developed to our needs that we can marry to the healthcare system and to the public health system that's really robust? We should be investing in these things with the expectation that we're going to need them sooner rather than later. So if I had a dream big, it would be to really not be so dependent on these external supply chains and to think about what we need to do to be resilient here so that we can support ourselves and support each other.
Libby, do you feel somewhat confident that we are better prepared now for a possible 10-year flood than we were in 2019, or are we not quite there?
I think there are areas where we're a little bit better prepared, and I think there are other areas that we now know we need to do more to prepare. My fear is that as COVID, starts going down, then people forget about it, and to really have to resource and make sure that we're supporting these things. I worry that that's going to fall by the wayside. When public health is working well, it's invisible. And so then when budget cuts come through, it's one of the first things to go because people don't really appreciate the value of it. And I'm hoping that we don't repeat that mistake.
Yeah, I would like people to think of public health like firefighters. Nobody complains about firefighters sometimes sitting around. They're not really sitting around, they're working all the time. But you want to have overemployment, and they can do other things, but so that you're ready to respond to emergencies. And it's kind of clear from this conversation that we also just need a lot more robust and embedded, more tentacles of health care and reciprocity across the communities. Okay, last question. One change, this is thinking a little bit more modestly and practically, one change, but a big one that you'd like to see come out of this pandemic in Hawaii, one policy change that you would think would make us, a stronger, healthier, more resilient community. Mark.
Okay, I'm going to be incredibly tactical because we're talking about getting ready for the 10-year flood. But just like when we found out asbestos causes mesothelioma and we had to pull it out of the ceiling, now that we know we're going to be faced with ongoing COVID and maybe in the future new respiratory infections, maybe we need better regulations on filtration systems in buildings. MERV 13 or better. Maybe we need far UVC lights in buildings just to make it less transmissible for the next one.
I think that makes a lot of sense.
I mean, I would say, honestly, the communications technology. So this is with the big data, but also to be able to connect our most vulnerable people. There's a lot of, that's more than one policy, but there's a lot, it just, that infrastructure needs to be there and be better.
To be able to convey information and receive
To
information
convey
with
information, again, to communities internally, the data exchange, you need very, very robust data systems. And to do that, you actually need broadband everywhere. And, people working on that, but you've got to have that connectivity.
Minimum wage passed this session. I'm going to say sick leave next session. Yes. Jonathan, one idea?
A locally developed lab test. The ability for a future mayor or governor to say, I would like a test for the following pathogens, for him to be able to customize that, him or her to be able to customize what test he wants, for that to be locally produced with a resilient supply chain, and for it to employ smart graduates of our universities so that they can work in that industry.
Libby?
I'm keying in on what Mark says. I think ventilation in buildings is huge, and I'm not sure I understand why it hasn't been paid attention to more robustly. It seems like it's very doable, and then I think it's just that workforce development. We have a lot of work to do for workforce development.
Building ventilation noted. I will organize a program on that. There's a lot of international experts who are thinking about this a lot.
Yes.
They just maybe haven't gotten as much public policy traction as
Agreed.
they should. But yeah, that can be important, and it can improve health and will help every flu season.
Absolutely.
Any final word from any of you? Thank you.
Thanks.
Thank you. Aloha, mahalo for all of your hard work and leadership and dedication, tireless dedication over these many, many months in helping keep Hawaii safe. It has not been easy. I know you all have argued with yourselves, among yourselves, collaborated. You've done a lot, and we're grateful for it. Thank you for joining us today. We'll be writing this history for many years to come, but it's important, I think, to pause and take stock of where we've been and think about where we might go. So thank you for joining us today.
Thank you.
Thanks for having us.
Thank you, everyone, also for watching. I wanted to say that the UH Better Tomorrow Speaker Series is a partnership with Kamehameha Schools and Hawaii Community Foundation. Our health policy sponsor is the Queen's Health System. I want to thank the College of Social Sciences Digital Studio, where we're shooting today, and all of the students who work for BTSS and for the studio. So thank you, everyone. It was a community effort. Aloha.